Good day, everybody. This is Chris. I hope you're doing well. I want to make a quick video to address some feedback that people are getting from Dr. Diven during the charting QA QI process. And I just want to reiterate a couple of resources that I talked about earlier in the course. So if you go to the OEM 240 homepage under the clinical resources module and the charting resources modules, more specifically the charting resources module, you'll see this D-chart narrative worksheet and this Platinum Planner and D-chart documentation review. This is a link to a video. It's about an hour long that I created that covers this in detail. I'm not going to redux that in this short video that I'm making, but I do want to remind you all that I have this narrative worksheet loaded in, and you can use this as a skeleton to create your patient care reports. You can use this as a narrative for typing those PCRs in, and then you can add those files into Platinum Planner. And I just want to go over that real quick one more time. So this is what I'm talking about right here. This is that narrative worksheet. And you see I have a blank skeleton set up for you all to use. And you can simply, as you're documenting your patient care, you can just simply fill in the information in each component of the D chart, right? Your dispatch, your chief complaint, your history, your assessment. Remember, we do require differential diagnoses, at least 3 of them, as well as documenting your confidence level and why you selected a specific confidence level, treatment, transport, and any special exceptions you want to discuss. A couple of people have asked me about the assessment. Dr. Diven is, again, very specific about the assessment, and he wants you to include pertinent positive and pertinent negative findings for all of the major components of the assessment. Remember, a pertinent positive is something that exists that shouldn't. For example, deformity, pain, swelling, adventitious lung sounds, right? These are things that are present that shouldn't be. And then pertinent negatives are findings that are things that you don't find that you would expect to find. For example, somebody has a loss of sensation, say. That would be an example of a pertinent negative. So the general way that you want to address your history in physical exam section is just like I have it in this document here. Starting with your history, you have your sample history, or rather your ample history, because the signs and symptoms have been documented in other areas, right? Your allergies, reactions, intolerances, a medication list to include doses and frequencies, and of course routes if at all possible, past medical and surgical history, last oral intake, and any events leading up to the current illness. This is, of course, also known as the HPI, or the history of present illness. All right. And then more focused questions on the history of present illness include the OPQRST, right? Now, when it comes to assessment, remember when I talked about assessment, you want to take a systematic approach to assessing, or to documenting your assessment at least. You want to document it in a systematic manner, and you want to do it pretty much the same way every single time you document, and then you get in the habit of developing a specific paradigm that works for you. And this is a paradigm that I put in you can use. If you choose not to use this, you need to choose some sort of systematic approach that is similar to this, that covers all of these components. So generally speaking, we're looking for you to document a general impression. The general impression is just a short couple of sentences, just a kind of a, what did you initially notice when you're looking the patient over, right? What do they look like? Okay, what's your general impression? Are they awake? Are they oriented? Are they breathing? Right? Those kinds of things. And then followed by the baseline vital signs: respiration, pulse, blood pressure, and temperature are mandatory on every patient contact unless there is some explanation for why you couldn't obtain those. And then, of course, CO2 monitoring is going to vary from patient to patient. You also want to include height, weight, and age if it has not already been identified. And then we start with the head-to-toe, treat-as-you-go kind of thing, right? You start at the head: ears, eyes, nose, throat, all right? What are the pertinent positives and negatives? And if there aren't any pertinent positives and negatives, chart that as well. Chart, right, that the head is atraumatic. The patient denies complaints. The pupils are brisk and reactive bilaterally. The patient denies any head, ears, eyes, or nose and throat complaints. That's acceptable. It's just you can't breeze over these components of the assessment by putting something like normal or within normal limits or anything like that, where that really doesn't show us that you actually assessed, right? So you need to get a little more granular in your assessment. Even if there aren't pertinent negative or pertinent positive findings, you still need to articulate that you did the assessment and what did you find. So head to toe, so head, ears, eyes, nose, and throat. The cardiovascular, right? So listening to heart tones, S1, S2, looking at the capillary refill potentially if you want to include that as part of your cardiovascular exam, what you see on the ECG, any cardiovascular complaints. All right, move on to pulmonary thoracic, right? So this is the chest, listening to lung sounds, looking at chest rise and fall, complaints of dyspnea, adventitious lung sounds, etc. The back exam, don't forget to look at the patient's back or ask them about it at least. A gastrointestinal abdominal exam, right? Inspection, right? You want to inspect it. You want to percuss, you want to palpate, and generally speaking, auscultation is going to be of limited to no value in the pre-hospital setting for the most part. Genital urinary, right? Again, ask the patient. If they deny complaints, put that. Patient denies complaints. A complete physical exam was deferred to focus on other issues, right? So if this is somebody having chest pain and you suspect acute coronary syndrome, you might defer certain components of this assessment. And if you do that, if you choose to defer, you need to explain why, as I did earlier. Obstetrical considerations, if applicable. Okay, an OB exam may not be applicable. The integumentary, that's looking at the skin, right? What is the condition? What is the color? Is it warm and dry? Is it pale and diaphoretic? What's the capillary refill? Are there any abnormal colors, right? Such as jaundice. Musculoskeletal exam, all right, arms and legs. And then mental status and neurological exam. And if you suspect some neurological issues, you might opt to do a more detailed neurological exam, such as a cranial nerve exam, or maybe a pre-hospital stroke exam, either a CPSS or LAPSS, or a posterior stroke exam, all right? So I understand it does make for a little more work, but this is really what we're looking at. And we understand that what you all are doing, because most of you are working as EMTs for various services, this is not how you're charting. Most of your charts are kind of little drop-down boxes or little clicking tabs and selecting things. And so we understand that's what you're doing at your services, but what we're doing here is we are trying to instill good assessment habits and trying to help you understand how to do a good assessments and how to develop good documentation habits. And at least you have a good baseline, and then you can use whatever paradigm is used at the service you end up working for, but at least you have developed a good baseline and you understand how to perform and how to document a good patient assessment. Because, like I say many, many times, history and physical exam is absolutely key to figuring a lot of problems out. All right, there are not a whole lot of diagnostic options available to us outside of the hospital that can magically make us arrive at a very specific diagnosis. And so we have to rely heavily on getting a good history and a good physical exam. And even if we don't figure out what's going on, being able to get that information and to convey it to the next level of care, to have that good continuity of care to where they might be able to take that information that we've gathered, marry it with higher level diagnostic information, and potentially get or arrive at a much more refined diagnosis and get to the right therapies for that patient. So it's actually very critical we understand how to do this from a patient care perspective and, of course, from a medical legal perspective. Okay, everyone, hopefully you found this video helpful, and I will see you all in lecture next week. Have a great weekend. Bye-bye.